Hypertension in pregnancy. Hypertensive disorders in pregnancies can be classified in the following ways. Chronic hypertension, or pre-existing hypertension present before 20 weeks gestation. Gestational hypertension, which refers to the onset of hypertension after 20 weeks gestation but without significant proteinuria or protein in the urine. Preeclampsia, hypertension in pregnancy and a multisystemic disorder of which proteinuria is the most common. Chronic hypertension may also be accompanied by presentation of preeclampsia symptoms. And finally, eclampsia. If a woman with preeclampsia develops seizures, she is said to have eclampsia. In this video, we'll be examining preeclampsia in greater detail, exploring the pathophysiology, risk factors, diagnosis and management of this condition. Preeclampsia. What is it? Preeclampsia is hypertension during pregnancy with multisystemic disorder of which proteinuria is the most common. It is diagnosed after 20 weeks of gestation in any pregnant woman who presents with a blood pressure greater than 140 over 90 millimeters mercury and with a significant degree of proteinuria. Proteinuria reflects underlying renal injury due to hypertension. In preeclampsia, significant proteinuria is defined as a total urine protein greater than 0.3 grams a day in a 24-hour sample, or a spot urine to protein creatinine ratio greater than 30 milligrams per millimole in a random bedside sample. Proteinuria may not be necessary to diagnose preeclampsia. For example, HELP syndrome can happen without proteinuria. Pathophysiology of preeclampsia. In normal pregnancy, the spiral arteries in the placenta dilate to 5 to 10 times their normal size due to trophoblast invasion and develop into large uteroplacental arteries capable of delivering large quantities of blood to the developing fetus for optimal circulation. Soluble pro-angiogenic factors like VEGF, PLGF, TGF-beta1 maintain patency of these arteries. In preeclampsia, trophoblast invasion is shallow, and the uteroplacental arteries become fibrous, causing them to narrow, which means less blood gets to the placenta, resulting in placental ischemia. For the mother, the ischemic placenta releases anti-angiogenic factors, SFLT1 and SENG, which inhibit the activity of pro-angiogenic growth factors and release pro-inflammatory proteins into the mother's circulation, causing the endothelial cells that line her blood vessels to become dysfunctional. When this happens, it causes vasoconstriction, narrowing of the blood vessels, and also affects the kidneys in a way that makes them retain more sodium, both of which result in hypertension and the clinical features of preeclampsia. Risk factors for preeclampsia. The risk of developing preeclampsia increases in mothers 40 years or older, or those with high body mass index. Preeclampsia also tends to occur more often during a first pregnancy, in pregnancies with multiple gestations, or if the mother has a history of previous preeclampsia. Other risk factors include having pre-existing hypertension, diabetes, obesity, or connective tissue disease such as SLE. Abnormal uterine artery Doppler showing raised resistance with notching could also indicate increased risk of developing preeclampsia, as it serves as a sonographic marker of poor placental perfusion, which is fundamental in the development of preeclampsia. Clinical features of preeclampsia. There can be a wide range of symptoms. For some women, there may be no symptoms or only mild ones, whereas for others, it can turn into a life-threatening illness. Some clinical indicators of preeclampsia could include the following: accelerated weight gain due to water retention, bilateral lower limb swelling and headache can be concerning symptoms of preeclampsia. Rise in the blood pressure is the most significant sign of preeclampsia. Preeclampsia is defined as the presence of 1. A systolic blood pressure, SBP, greater than or equal to 140 mm mercury, or a diastolic blood pressure, DBP, greater than or equal to 90 mm mercury or higher. On 2 occasions, at least 4 hours apart in a previously normotensive patient. Proteinuria of more than 2+ on a urine dipstick, coupled with high blood pressure, is a red flag and requires additional investigations to exclude preeclampsia. Hyperreflexia on assessment of deep tendon reflexes could also be an indication. Diagnosing preeclampsia. When diagnosing preeclampsia, the investigation is targeted at assessing the degree of proteinuria and evaluating for complications of severe disease. The following tests should also be run to evaluate risks for potential complications: full blood count, liver function test, coagulation profile, renal panel, serum uric acid level, and fetal ultrasound. Clinical consequences. Preeclampsia causes complications in both mother and fetus. Neurological. The extreme increased blood pressure could lead to hypertensive encephalopathy, causing fluid accumulation in the brain or cerebral edema, and consequently seizures. The seizures define the onset of eclampsia in the mother. It could also lead to intracerebral hemorrhage, ICH, and temporary blindness or amaurosis as a result of focal edema in the occipital lobe. ICH is the most common cause of death in preeclampsia. Cardiopulmonary. Movement of fluid, what is known as third spacing, can result in pulmonary edema. This will result in the need for fluid restriction, which needs close clinical monitoring. Biochemical. As a result of endothelial injury, thrombi are formed in the microvasculature. Having all of these tiny blood clots in the blood is treacherous for red blood cells to navigate through, as the possibility of being sheared becomes higher. This is known as hemolysis. Preeclampsia can also cause localized vasospasm, resulting in less blood reaching certain organs such as the kidneys and liver, which can result in reduced urine output and hepatocyte injury. These would be reflected in laboratory tests as a raised serum creatinine, raised uric acid level, and transaminitis. Microthrombi can also form in such narrowed vessels, and disseminated intravascular coagulopathy is a risk. Reduced blood flow to the liver can cause severe liver injury and swelling, which can cause an elevation in liver enzymes and stretches out the capsule around the liver. This can cause pain in the right hypochondriac region in the abdomen. Reduced blood flow to the kidneys leads to oliguria, very little urine, and proteinuria. Together, these make up HELP syndrome. H equals hemolysis, EL equals elevated liver enzymes, LP equals low platelets. HELP syndrome develops in about 10 to 20% of women with severe preeclampsia or eclampsia. Vasoconstriction results in uteroplacental insufficiency, which may be acute and lead to fetal distress or in utero fetal demise in severe cases. It can also be chronic and lead to intrauterine growth restriction, IUGR. Vasoconstriction also causes placental ischemia, which could lead to placental abruption, in which the placenta detaches prematurely from the uterine wall. Management of preeclampsia. The aim in the management of preeclampsia is to balance the needs of both fetus and mother and optimize the outcomes for both. In the presence of severe hypertension, measured as BP more than 160 over 100 mm mercury or MAP greater than 125 mm mercury, the patient should be admitted into hospital and managed for inpatient treatment, and antihypertensive medications such as oral labetalol should be started. Other oral medications include nifedipine or methyldopa. Management of maternal condition. Obtain a baseline assessment of biochemical and hematological parameters on admission and trend these investigations at least twice a week should severe disease such as HELLP syndrome develops. Magnesium sulfate is used as a prophylactic treatment for eclamptic seizures and should be started in women with evidence of severe preeclampsia. Once initiated, however, delivery should be done within the next 24 hours. Management of fetal condition. If delivery is considered likely within 7 days for women between 24 to 34 weeks gestation, a 2-dose regime of intramuscular dexamethasone 12 mg is given 12 hours apart to promote fetal lung maturity and reduce risk of respiratory distress syndrome at birth. Some hospitals will use 2 doses of intramuscular betamethasone 12 mg 24 hours apart, or 4 doses of 6 mg dexamethasone administered intramuscularly every 12 hours to achieve the same effect. Serial assessment of amniotic fluid index and umbilical artery Doppler should be done weekly and monitoring fetal growth every 3 weeks. When in labor, continuous fetal monitoring via cardiotocography (CTG) is recommended. Labor and delivery. Because all of the problems of preeclampsia and eclampsia stem from placental dysfunction, the ultimate treatment is delivery of the fetus and placenta. Emergent delivery or emergency cesarean section is indicated in severe PE with uncontrolled BP, eclampsia, pulmonary edema, HELLP syndrome, placental abruption, fetal compromise. The following are considerations regarding delivery in patients with preeclampsia. Patients with severe preeclampsia must be delivered as soon as possible and preferably after completion of corticosteroids if patient is between 24 to 34 weeks gestation. Patients without severe features of disease are delivered from 37 weeks gestation. Vaginal delivery is not contraindicated and cesarean section is reserved for the usual obstetric indications. Use of epidural and spinal analgesia are relatively contraindicated if maternal platelet counts are less than 75 times 10 to the power of 9 per liter due to risk of neuraxial hematoma and paralysis. Eclampsia. Eclampsia occurs when a patient develops seizures from preeclampsia. It is a serious complication of preeclampsia and constitutes an obstetric emergency. When seizures occur, it is important to take the following steps. 1. Protect the maternal airway by supplementing oxygen and turning the patient to the left lateral position. 2. Stop the seizures with magnesium sulfate using the collaborative eclampsia trial regimen with a loading dose of 4 grams given intravenously over 5 minutes, followed by an infusion of 1 gram per hour maintained for 24 hours. Recall that if the fetus is still in utero, delivery must be expedited within 24 hours. Patients on magnesium sulfate should be catheterized for strict monitoring of urine output and examined frequently for signs of magnesium toxicity. 4. Control blood pressure using oral or parenteral medication. 5. Terminate the pregnancy at any gestation by the most suitable method, either cesarean section or vaginal delivery, in the interest of the mother. Chronic hypertension. Finally, chronic hypertension in pregnancy is defined as the presence of hypertension before 20 weeks gestation or hypertension present before pregnancy. The main concern with chronic hypertension is the high risk of developing superimposed preeclampsia or eclampsia as the pregnancy progresses. Chronic hypertension in pregnancy should involve close monitoring of maternal blood pressure and proteinuria, as well as monitoring of the fetus for appropriate growth, and these mothers should be ideally followed up at the high-risk obstetric clinic. Start low-dose aspirin, 100 mg per day, before 16 weeks gestation until birth to reduce risk of superimposed preeclampsia, especially when there are known risk factors. Measure serum creatinine and obtain 24-hour urine collection at booking for baseline assessment of renal function and proteinuria. And assess blood pressure and urine dipstick for proteinuria at every subsequent antenatal visit. Obtain regular series of ultrasound assessments of fetal growth, amniotic fluid index, and Doppler assessments to check for IUGR, oligohydramnios, and raised uterine artery resistance. Consider delivery from 37 weeks of gestation unless superimposed preeclampsia warrants earlier delivery. Thank you for watching this video. This video is presented by Yongloo Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.